Welcome back everybody to my channel. In this session, I'm going to talk about good positioning in off-pump CABG. Good positioning is the cornerstone to do off-pump safely. What's the definition of good position? Good position is the position that provides an excellent exposure to the surgeon. As I always say, if you can see, you can do. So the surgeon should see very good and clear field. Okay. So a good position is the position that provides a good exposure and good hemodynamics. What I mean by good hemodynamics is not good monitor. I mean, not only the ECG and the blood pressure are fine. No, the heart should look well, should not look compressed or straining. So the aim of good position is to get good exposure and good hemodynamics. Take your time in putting the heart in an excellent position. Take whatever time you like. I want you to take the anastomosis in a very easy way, and you are not running out of time, and you are not having different hemodynamic problems and so on. I need you to take the anastomosis. You open a generous incision in the coronary and take the anastomosis as easier as possible. So, how to obtain a good position? First of all, a generous incision is needed. You cannot do provide a good position with small median sternotomy incision. You need a generous incision. This is number one. Number two, the retractor. I prefer the CTS guidance retractor. However, the Coley and the Morris retractor are also provides also a good position. Why I prefer these retractors? Because it provides wide range of movement for the octopus or the stabilizer. So that makes the surgeon puts the heart in a more easy position. Okay. Number three, no off pump without a shunt. You should use an intracoronary shunt in all types of, in all anastomosis, in all targets, because the shunt protects the angles, protects the heart from air embolism, and maintains the blood flow during your anastomosis. Okay. So no off pump without a shunt. Precardial stitches are very important. You need the left-sided stitches should be taken as deep as possible, because pulling on those stitches makes the heart rotate toward the surgeon, and it provides good exposure for the lateral targets, which are the most difficult targets in off-pump CABG. Opening the right pleuropericardial reflection is one of the most important steps. I do this in all patients having lateral targets, because this allows the heart to be to herniate through the right pleural cavity while exposing the lateral targets. So it provides good exposure for the surgeon and avoids compressing the heart between the stabilizer and the pericardium. Another thing is to do the distal or the proximal anastomosis first. I usually do the distal anastomosis first, and I will start with non-LED targets. I start with the lateral targets. Why I start with lateral targets? I know this is against most of the surgeons, but I do this after long way. I decided to settle this technique. Why I start with the lateral targets, OM, Ramus, diagonal, then proceed to the LED? Because if you started with the Lima to LED, you and then you proceeded to OM, Ramus, or diagonal, you might have stretched Lima to LED. This is number one. Number two, this limits the exposure of the lateral targets. Number three, this limits your options in putting the heart in different positions. And as I said, the position is very important. So if you put Lima to LED and then you start to the distal anastomosis of the OM, for example, you might have some limitations in putting the heart in at ease position. What about heparin? I give full dose heparin and half dose proton at the end of the procedure. Why full dose heparin? Because I start with the lateral targets first, the distal lateral targets first, or the distal targets first. So it takes maybe 30 or 40 minutes to proceed to the proximal anastomosis. So during this 30 or 40 minutes, the blood stays in the vein, and this might initiate a thrombus. So I do not give half dose heparin at all. Full dose heparin is a must. ACT above 400. Then after finishing the procedure, I give just half dose proton. The proximal anastomosis. The proximal anastomosis is the same as on pump. However, you don't have the space to put the C clamp in wide, or you cannot take a good bite of the aorta because the heart is beating. So if you take a large bite of the aorta, this may result in hemodynamic instability. So put the C clamp, try to take as less bite as possible. Take your time dissecting over the aorta. Check that the C clamp did not cause any hemodynamic instability, neither by the monitor nor by straining heart. Make sure that the heart is beating well and it is not strained after putting the C clamp. Then start doing the proximal anastomosis one by one. Do not open 2 or 3 openings in the aorta, then start the proximal anastomosis. No, because if you open 2 or 3 openings and then you get any hemodynamic instability, you will be in trouble. So put the C clamp, the least possible bite. Take your time to make sure that the C clamp did not cause any hemodynamic instability. Start putting the proximal anastomosis one by one. Thank you so much.